Now I invite Dr. Anurag Mishra. I've seen some of his video and where he has managed the complicated nucleus. So I thought he'll be the apt person to demonstrate how to handle the nucleus once the PCR takes place. And the only thing what if you don't have an endo illuminator, because most of the phacoemulsification, the tip is away from the incision. That means if you are doing a temporal, then if the opacity is on the nasal side, it will become very, very difficult. So your incision should be, our tip should be placed in such a way that if your opacity is nasal, if you do the superior, probably you get a cleaner area to operate upon. So that is very important to where to place the incision in cases of corneal opacity. And Jepto is a very good for ensuring that you get a round rhexis. So once you got a round rhexis, then if you manage somewhere in the clean area, somewhere if there is some transparent areas there, probably you can go ahead and do the phacoemulsification even without endo illuminator. Dr. Anurag Mishra.
Right, sir. Thank you so much, sir. Good afternoon, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. I'm not going to speak anything new to this because this is something that we have actually learned. This is a stepping stone of learning cataract surgery, the event of posterior capsular rupture and the further nucleus management or whatever is left in the bag or in the eye, the removal of the same to ensure that there is everything clean before you implant an intraocular lens. So what I'm going to do is to concisely refurbished presentation of what we have already learned. So I'm going to share with all of you 3 twos in the next 6. That's the correct way to put it. The first of those twos is 2 mantras. One of them is the memory, the remembrance that the nucleus is not something that is going to be absorbed on its own. So if you have the fragment dropping in, you have to take the assistance of a colleague, and most of us, like me, are standalone private practitioners, so we do not have an associate who deals with vitreoretina. So you have to refer them to another center for the same. The other mantra is to put your vocal cords to rest. There is no mistaking that you will panic in the event of a posterior capsular rupture. But however panicked you are, it should not extrapolate onto your tongue and the voice box. So keep yourself muted and ask your associates who are roaming about in the OT also to put themselves in the mute format. 2 essential inclusions in the inventory. Once the PCR happens, you have to protect 2 important structures. One of them is already ruptured, which is a posterior capsule, and the other is the delicate endothelial cell layer on the undersurface of the cornea. So the 2 important inventories you should have is a dispersive OVD, and I would advise the inclusion of chondroitin actually as the dispersive of choice, because we know that this is the most negatively charged molecule available to us in the market, so it spreads more widely and protects the endothelium essentially like a sheet. It also protects the capsule, provides a capsular bandage sort of a thing, and protects the capsule and gives us the space to operate upon. We'll see that in the form of certain videos later on. And the other is, of course, the multi-piece IOLs, PAR corrected, both for sulcus and bag, whichever you need can come into play. The third 2 that I would be sharing with all of you is the 2 points to ponder. One, essentially we have to recognize the PCR happening early, at the earliest stage possible, and to prevent its extension, of course. And then to continue with the nucleus fragmentation as we were doing up till that point in time. So these are the 2 points that we are going to expand on. How do we recognize it early? One of these things is to see the hole happening. So there's one learning point here. Look at this hole happening in the periphery. So the first learning comes right here. Never ever to take the phaco needle too peripheral. It does go peripheral when the cataract is soft, but we have to find out a way in which we remain at the center. So just go down on your power, learn to control your foot switch, chop more with vacuum, less with power. That's the trick to do it. And if you're not comfortable doing that, go ahead to the old school, go back to the old school and trench and then divide. So you see the hole and recognize it early. This is a very hard cataract, as you can see, and this patient is high myopic. Look how it goes. The first segment that was to be chopped was this, and then we subsequently keep on chopping. Look at the first segment that we had chopped. It goes underneath the iris and almost is in the process of getting lost. The whole bag was filled with nucleus. Now suddenly you find a lot of space here. This gives you a signal that something's wrong. So you have to go back and revise what's wrong in there. So that's the second point, how you would recognize an early happening of a PCR. The third is, of course, apart from seeing a rupture happening in the posterior capsule, if you'll notice, there's a posterior polar cataract, as you can see, and we can already see a rupture happening vertically out here. But what I'm going to show you is a small nuclear fragment, and a small nuclear fragment, and look at the way it fibrillates there. So a larger nuclear fragment will also fibrillate. Look at this nuclear fragment here as it fibrillates. So what happens here is the endophthalmodonesis that happens, which essentially does not transmit to the nuclear fragments just because there is a physical barrier in the form of posterior capsule. Once it ruptures, the endophthalmodonesis does transfer to the nucleus fragments and they start fibrillating. So that's when you know that something's wrong in the posterior capsule. So this is how you recognize it early. This is an age-old teaching. You mustn't do this. This was one of my old amateurish video where the rent happens and they're inside. The rent happens and is suddenly panicking, withdraw the phacoprobe and it expands the rent essentially. So this is something you should never ever do. Substitute that with viscoelastic before removing it. That prevents the extension. This is something you can do after you see the hole, just change your business area. This is where the hole has happened. So you change your business area to diagonally opposite or radially opposite sector and then carry on with emulsification, aspiration of the rest of the nuclear material. Of course, you have to protect the posterior capsule by providing a bandage with the help of dispersive viscoelastic, but this still becomes a little easier because the rent happened in the peripheral portion and the central portion is still free and you can still utilize that as your business area. The other thing that you can do is when you have the last fragment in, you can lift it up after putting in some viscoelastic out of the bag and then can proceed with the phacoemulsification. So once it's out of the bag, you can protect the endothelium with dispersive visco, you can protect the posterior capsule with dispersive visco, and then can still carry on with your job that has been unfinished largely. Still, if you're not comfortable, what you can do is go ahead and use what is known as the IOL scaffold. It has saved many surgeons and many faces time and again, and you can put in the IOL in first, and then can emulsify this hard piece of nucleus, all the while protecting the endothelium as many times as required. Just keep on replenishing it with dispersive viscoelastic. Now, all that teaching does not come into play when you have a situation like the following one. Herein was the patient who had a posterior polar cataract, and look at the anterior segment OCT picture. The whole posterior capsule has given way. It's like a dragon which has already opened its mouth, and you just cannot see the spitfire because the cataract was total white and mature. So what you do in this sort of cases is that you cannot manage this nucleus while it is still inside the bag. So what I do is, after a minimal hydro, you have to tire liver the nucleus out. You just cannot manage this nucleus inside the bag. And you cannot do anything to put in the scaffold as well because you can't see the posterior capsule. You don't know where the haptic will go in. So you first of all fragment the nucleus impromptu in the anterior chamber, create a corridor of visibility out here, push these segments into the periphery, and now put in the IOL in. Take the advancing haptic into the sulcus, keep the optic in the pupillary zone, the trailing haptic remains somewhere in the iris, protect the endothelium, go ahead and chop and finish off the business with the nucleus, and then the epinuclear plate, and then roll the trailing haptic into the sulcus to finish off the procedure. So that's all I have to say. Thank you so much for the attention.
Thank you, Dr. Anurag. How you manage the epinuclear plate after putting the IOL in?
So what I do is, if the posterior capsule is already open, I do not go in with the vitrector because once you remove some amount of vitreous from the area and create a gutter there, it tends to drop down even to the center of the vitreous cortex. So what I do is I use the IOL optic as a nudging device, keep retracting it towards me and then leave it. Keep retracting it towards me and then leave it. So the IOL optic nudges against the epinucleus and lifts it up to the surface of the optic, and then it can be consumed easily. So I don't disturb the vitreous face much and eat away the superficial vitreous cortex while the epinucleus is still lying there.
So excellent technique. I have never used it. But normally what I do, I mean, I'll go and try out this because I feel I have dropped more EP nucleus into the vitreous cavity than nucleus, because nucleus is something you can hold, but EP nucleus you can't hold. Cortical fibers you can hold, but the EP nucleus is the one which does not come, you are not able to grip and pull it out. And I feel that once you put the infusion from the top, then there is a pressure from the top and then EP nucleus goes down.
Absolutely. And if
So
you
if you
try
put
to
an
aspirate it,
infusion
it
from
comes
the
out.
pars plana,
Yeah.
and then if you do, then it will have a tendency, because the fluid will be coming from the back to the towards the front side. So the chances of dropping EP nucleus will be much less. And if you put instead of putting the infusion from
I
the
have
top.
tried the posterior levitation of epinucleus in some of these cases, but since you already have a barrier in the form of the optic, it just doesn't lift up. So
Good idea. I'll be